Hello, hello. Hi, this is Jonathan Munoz again for another episode today. I have more time, so I'm going to start talking about the inpatient service. And we're going to start a series of how not to suck on your first rotation, on your observership, or on your first year as an intern in the inpatient medicine service. And this applies for internal medicine or for family practice or for any resident that has to start an inpatient medicine rotation, because as you know, many residents that apply, for example, to dermatology, they have to do a year of internal medicine. So let's start with this part. And the first topic is who gets admitted to the hospital. Okay, so let's say the 3 or 4 residents interns are assigned to the inpatient medicine service. So now you know there's 3 interns, there are 2 senior residents, and there's 1 supervising attendant. So what you guys will do is you will run the inpatient service. You probably will have around 20 or 30 patients in the inpatient ward of the hospital that's managed only by you. Well, by your attending supervising physician, but you are the supervising physician eyes and hands, because he is out of the hospital. He's leaving all to you. He supervises you, but you are the one managing everything. So the first thing is, now you're sitting in your residency lounge and you're waiting for what? You're waiting for an admission. Not many people like admissions because there's a lot of work to do when an admission comes. There is a lot of talking, typing notes, but that's the work that we have to do. And I always have the idea that if you start liking it early in the process, if you start liking the difficult cases early in the process and learning from them, the easy cases come as nothing later. Whereas if you only want the easy cases and you don't want to put some mental work for the difficult cases, then you might get in trouble at some point because you can only fake it for so long. So let's try to look at this with very much of a positive attitude and see what can we learn today. So the first thing is you're sitting on the lounge and residents still have something that is a beeper, a pager. And so you're sitting in the lounge and you get a beep or a page that says ER admission request. Call Dr. Munoz in the ER for a possible admission on bed 20. And the admission is on chest pain. So you don't decide yet who is going to be admitted to the hospital. The one that decides this part is the ER doc. Why? Because the patients first come into the hospital through the ER doors and they start talking to the ER physician, and the ER physician says, well, I think your condition deserves observation or deserves further workup that may take more than 2 days, so you will have to stay in the hospital. Or if it's a simple problem like, I don't know, missing on medications and feeling sick because not taking his insulin, then the ER physician can give a new prescription for this medication and send them out. Or let's say this patient has been having cold symptoms and having chills. So the ER physician does a simple assessment and thinks, okay, this is likely viral. I think you can go home. Or the ER physician says, well, chest pain on a patient that has so many risk factors like diabetes and hypertension. Let's calculate your heart score. 5 points on the heart score. This patient needs admission and at least observation. So let's call the internal medicine or the inpatient hospitalist to admit this patient. Or there comes a code from home, a patient that had an arrest and is being resuscitated on the way here. So this patient probably will need to be admitted for further workup if he survives. So let's call the hospitalist for that. So the ER physician decides he doesn't decide, but he has an idea or who to call for a possible admission, because not everyone that comes to the hospital is going to be admitted, but it's different in other countries. There in a hospital in the emergency area there are a internal medicine side, there's a surgical side, there is an OBGYN side, but here in the United States, there's always only the ER or the emergency department as the gatekeeper for everything, for OBGYN, for internal medicine, family medicine, pediatrics, or surgical cases. They determine who needs what they need and if this patient is going to stay. And then they call you, the intern, the resident, the even attendants that are working on seeing their own patients. So that's the way how an admission is determined. Okay, so that was the first topic for today. Very short, but hopefully gets to the point. So now you understand what is the dynamics. Once the intern or the residents are called for an admission, are paged for an admission, then the intern or the resident that is holding the pager that day assigns that patient to the person that has less patients, the person that's next to take an admission, and it rotates. So you may take the first one, then your partner will take the second one, and then you go back to take the next one, and then he takes the other one, and so forth. Very simple, but that's kind of the idea. Okay, thanks.